Hello friends, let's talk about how to approach a patient presenting with fever step by step like a clinician. So step 1 is a history. Start with a detailed history. Ask about duration of fever, like is it acute, subacute or chronic fever. Now what is the pattern of fever? Continuous fever, intermittent fever or remittent fever. Now explore associated symptoms like chills, rigors, rash, sore throat, cough, abdominal pain, joint pains or urinary symptoms. Don't forget exposure history, recent travel, insect bites, unpasteurized milk, TB contact, IV drug use or unprotected sex. Also ask about medication use or recent hospitalization. You might be dealing with drug fever or nosocomial infections. Now step number 2, that is examination part. So a focused physical examination is key. So check for the vitals, especially temperature pattern, pulse temperature dissociation, blood pressure, SpO2 monitoring. Also look for the clues like rashes, lymphadenopathy, pallor, jaundice or mucosal ulcers. Check for meningeal signs also, neck stiffness and photophobia. Palpate for hepatosplenomegaly. If hepatosplenomegaly is present, think of malaria, Kala Azar or enteric fever. Listen for crepitations, might be a case of pneumonia, or a new murmur, that is might be case of infective endocarditis. Now step number 3, that is initial workup. So it starts with basic investigations like CBC with differential count, malaria test, dengue NS1 or IgM, typhoid test like Vidal or typhoid in endemic areas. If patient has urinary symptoms, always do for urine analysis and always send urine culture, blood cultures and chest x-ray. If patient is toxic or septic, add LFTs, RFTs, CRP, procalcitonin and coagulation profiles also. In case of chronic fever, consider Mantoux test, ESR, ANA, HIV, TB gene expert and abdominal ultrasound. Chronic fever is due to tuberculosis, HIV, autoimmune or due to malignancy, so we have to consider all these reports. Now step 4 is we have to categorize fever in one of the following, like number 1 is acute undifferentiated fever common in tropical areas. Number 2, fever with localizing signs like pneumonia, UTI and meningitis. Number 3, fever with rash. Then we have to think of dengue, measles, rickettsia or SLE. Number 4, fever with cytopenias. Then we have to consider viral hemorrhagic fevers, malaria, leukemia. Number 5, fever in immunocompromised patient. Then we have to think of fungal infections, TB, CMV or drug fever. Now step number 5, so that is red flags. So watch for red flags. These need urgent interventions, like if patient is hypotension, altered sensorium, persistent vomiting, bleeding gums or petechiae, severe thrombocytopenia, respiratory distress or seizures. So these all are red flags. Then you have to act urgently, you have to admit the patient and treat accordingly. Step number 6 is management part. So we have to avoid blind antibiotic use. If there is no focus, give just paracetamol for symptomatic relief, ensure good hydration and monitor patient. Start with empirical antibiotic only if clinical suspicion is there or sepsis is present. Always tailor antibiotic based on culture reports. And finally, always reassess daily. Fever isn't always infectious. We have to consider other etiologies also, like autoimmune fever, neoplastic fever or drug related causes also. Fever is a symptom. It is not a diagnosis. So treat the cause and not just the thermometer. Thank you. Follow for more.